The topic for discussion is volume status assessment. This topic will be discussed under these following headings. A short introduction. Why volume status assessment is very important, especially for a medicine resident. First, it helps to titrate the fluids the patient is requiring. In ICU, it is the most important parameter with which the treatment plan changes. And the discussion that we are going to have is at the level of MD final year resident or a DM resident level, so that they will be knowing the basic terminology that I'm using and the context at which the discussions are there. So if you are a UG student, you can skip this video. First, in the ICU, very important, and as a nephrologist also, in the dialysis or in a cardiac patient or in any AK patient, the most important with respect to the urine output or stabilization of the patient is the exact volume assessment. And this being asked by many juniors also to make a video with respect to how we assess as a nephrologist, how we approach that we are going to see. To have an exact volume assessment in a patient, you first should be aware of the physiology regarding the fluids in the body. We take the total body mass in the entire body, 60% is the water. 60% of the body is being formed of water, that everyone is aware. Under that, 2/3 most are intracellular, 1/3 is the extracellular. In that also, 75% is interstitial fluid, only 25% is the plasma. So the volume imbalance happens whenever there is dearrangement in any of these. There might be loss or there might be shift in the fluid between the chambers to the third space, or there's a excessive body water. So these are all the problems with related to volume. There will be increased or decreased as in hydration or volume overload or shift of the volume where there is a significant edema. For example, in the case of nephrotic syndrome, albumin is not there, so there will be shift of intravascular to the interstitial space. So these are the volume derangement which can happen. And why we have to know the volume assessment, that is important. As a practicing clinician or a practicing intensivist, or if you are managing ICU, you should be knowing why you have been asked to assess the volume, because either the patient might be sick or they want to adjust the fluid or they want to remove the fluid whichever is high, or what are the impacts the patient was having, they want to bring the patient out of that impact because of the volume excess or low. So what are the most common conditions because of which the volumes can go haywire? Most commonly cardiac failure, heart can't pump, because of which there will be a increased hydrostatic pressure, there will be a lot of edema or involvement of the kidney in terms of either acute kidney injury or chronic failure, any kind of dysfunction. Liver failure where protein is not made, and through various pathophysiological process the patient might go into volume abnormalities. So these are all the three important organs with which, if involved, can go to volume derangements. These I made it in a particular pillar 1, 2, 3. Apart from this, there might be loss of water from the body or iatrogenically excessively might be given, as in the wards where excessive IV fluid might have been given for a patient who might not require that much. Apart from these kind of organ dysfunction, any other condition which can causes the some kind of capillary leak, as we see in dengue or sepsis or multi-organ dysfunction syndrome. These kind of the leaky condition where volume derangements can happen, or there will be these kind of loss from the body or excessive intake due to the hydrogenic supply. And if the patient is perfectly fit, unlikely increased water intake will lead to volume overload, because the captain kidney will take care of the homeostasis. If the heart is functioning accordingly, it will be excreted. So these are all the diseases the patient might be having, because of which there is a volume imbalance. So that is why probably the patient is in ICU or you have been called to assess the volume. So what are all the methods to do volume assessment? There is no single gold standard test. Using that, we can clearly say the patient is in overload or depletion. There are methods, each method having its own advantage and disadvantage. The methods can be classified as the methods that we use in a patient who are in ICU, in patient those who are not in ICU. Probably ICU patients are bedridden, they might not be cooperative because they are bedridden. You can't do some kind of procedures like orthostatic changes and all, you can't do. So the methods can be divided as the methods that we use in non-ICU cases and methods we use in ICU patients. Because in ICU you might require exact measurement. In non-ICU, probably approximate volume status might be good enough to manage the entire case. And the methods can be invasive techniques or the non-invasive techniques. These are all the two broad classification you can do with respect to the methods. If we come to the methods per se, what are the methods by which volume assessment can be obtained, or assessment can be guided and we can find whether the patient is in overload or depletion? First is the history. Many a medicine resident asks, sir, is history important to understand whether the patient is in volume overload or depleted? History is very, very important. You have to know what was the patient status before coming to the ICU, whether his urine output was adequate or not, whether he had any comorbidity, how much water he used to take, and since when the patient was getting sick, and what was the urine output or after admission. History is very, very important to get clue related to the case. For example, a 40-year-old male present with multiple episodes of diarrhea, multiple episodes of vomiting, and presented to the ICU in ultrasound serum, you can easily make out from the history only most likely patient might be volume depleted. The major clue, even as a nephrologist, that we use is the history. Always look at the input output charting the previous day. If the patient is admitted on a particular day, ask the history from the relatives if the patient is not able to give the history. So history is very, very important to make the probable guess how a patient might be in overload or depleted. That one example I gave with respect to the volume depletion. Another example, if a patient is a known case of diabetes and he is a case of CKD and he is getting dialysis, every time he is developing shortness of breath whenever less than 2 liters of ultrafiltrate is being removed. That also indicates the patient might be in volume overload, because more than 2 liter if it is removed from the during the dialysis, he feels comfortable. That means the history probably suggesting the patient might be in overload. The first is the history. Second one is the clinical examination to look for signs of depletion or overload. Third one is the imaging. Fourth one is the blood investigation, which we use to catch the volume status. Fifth one, even though it comes under imaging, nowadays a separate significant importance being given to this focus. This is point of care ultrasonography. Invasive methods. Invasive means there are some injections or needles being used, some foreign body being sent inside the patient body, and the diagnosis of volume status being made. Those are the invasive technique. And the last one is the bioimpedance. Bioimpedance, more specifically, we use in CKD patients, renal involved patient bioimpedance. So these are all the methods with which volume status of a patient can be assessed. As a medicine, particularly I'm saying as third year because in first year, second year, you have to see more cases, you have to encounter more of ICU scenarios. You might have seen the patient in the casualty. During that time, importance of history you might not understand. But once you become a third year, you know how important the history is, even with respect to a volume assessment. And another scenario I want to share in this slide, during the ICU rounds, some first or second year anesthesia resident will come. Sir, you are a nephrologist. Please tell me how to assess the volume in this patient stat. What is the technique? What you use? See, there is no particular one step. You do this, you will get. It won't occur. You have to use various parameters: invasive, non-invasive, imaging, history, examination. So these are all the 7 methods with which you can assess the volume status. So now one by one we will start seeing. All have sub-advantages: sensitivity, specificity, negative predictive values, all are there. Case as a whole, you have to see and analyze and interpret each reports. By that only you will come to know whether exact volume status we got or not. Especially these are all the scenarios in ICU, because a patient sitting in ward or patient who came in OPD, even you didn't assess the volume exactly, it is not going to have any impact. Whereas in ICU, especially renal involved patient, is going to have a huge impact on the patient outcome. First, history, as I told, very, very important. You have to ask regarding the urine output, volume status, edema, since when, what was his protein water intake, whether any history of fluid loss is there, what are the comorbidities he had, like diabetes, hypertension. If it is there, more of renal involvement possibilities there, any drug intake is there or not, if any IV fluids are given is there or not, how many fluids was given. These are all the important questions you have to ask from the history to make the approximate guess whether the patient is in overload or depletion. A patient who is having edema in the lower limb for a long period of time, up to 3 to 6 months or more than that, from last 6 months he is having edema, last 5 days he had multiple episodes of diarrhea or vomiting, because of which there is a loss of intravascular volume. Still, a patient with edema might be depleted also. That is why not all patient who's having edema will be in overload. Don't come to that conclusion. I'm just saying as an example. History you have to make it, and the probable guess you have to make what I'm expecting in this particular patient. Then coming to the clinical examination, the most useful, the most important technique as a doctor we can easily use even in ICU patient will be very, very helpful. Out of 100, probably 20 to 30 percentage might be uh, difficult cases where assessment can be difficult, but rest around 60 to 75 percentage of cases assessment can be very well made with the help of the clinical examination. We will see what are the parameters we will see. First is the blood pressure. In an overload patient, there is a chance the blood pressure might be on the higher side. In a depleted patient, it might be on the lower side. What is the disadvantage of this? There are many confounding factors. Patient themselves might be a hypertensive, so that might not work. But if a patient is grossly depleted, BP might be on the lower side. If the patient have lost a significant amount of fluid, the patient might be in shock. Is high BP always indicates volume overload? In a dialysis patient, if the BP is always on the higher side, probably that might indicate subtle volume overload. What is the sensitivity specificity? There is nothing to discuss regarding sensitivity and specificity with respect to volume overload and the BP. BP is one of the clue to suggest volume depletion. One of the clue to find the patient might be overloaded. First is BP, second one is the pulse. A pulse which is not in the normal range. For example, tachycardia. A tachycardia in a patient might indicates many things with respect to volume status. The patient might be in volume overload. You can see in your experience how many of a pulmonary edema patient had tachycardia before dialysis. Once the dialysis and volume removal was done, the patient pulse rate comes back to 72. All tachycardia indicates volume overload? No. A tachycardic patient, high chances he is not in homeostasis. Probably that homeostasis might be anything, including the electrolyte. Probably the patient might be in shock. But a tachycardic patient, if other clues are aligning, probably that might be a sign of volume overload. This, with experience, as your MD curriculum completes, you become a senior resident or assistant professor, whatever, you will start noticing the pulse. How the pulse is normalizing as the patient is coming out from ICU towards what? So a tachycardia patient might be having volume overload, most likely, or very rare cases, depleted patient might also have tachycardia. Third one is the skin turgor, skin elasticity. Skin elasticity will be very poor in dehydrated patient. It is an important clinical examination in a dehydrated patient, which will be very useful in a pediatric population. Even in adult population with severe dehydration, old age, skin turgor still most important. The fourth one is the presence of edema, presence of the edema in the lower limbs, presence of probably anasarca, swelling all over the body, again indicates the overload. Dry mucous membrane. Mucous membranes might be dry, indicates severe dehydration. And one more thing that previously been described in the book is the axillary sweat. Even few physicians using that axillary sweat, whether axillary sweat is there or not, if it is not there, probably it is a sign of dehydration. So in a normal patient without much confusion, with which you can try to easily catch a volume overload. And again the question comes, if edema is there, will it always is overload? It might not be. Intravascular volume might be depleted. Edema indicates interstitial fluid. From the intravascular space, the fluid might have entered into the interstitium. Intravascular depletion might be there. Probably this might be somewhat confusing, probably even for a third year resident. I hope DM residents are getting the concepts. All these being discussed with respect to ICU scenario, not in a single patient, in each scenarios. All together have to be taken into consideration along with the patient disease and try to come to the conclusion. Clinical examination still not over. So BP, pulse, skin turgor, edema, mucous membrane, and axillary sweat. Apart from this, what are all? Repetition. Whenever we ask the first year whether the patient is in overload or depleted, the first answer everyone will say is, sir, there is no crepitation. The crepitation might or might not be there in a volume overload patient. Probably these are the finding which might be there in an advanced overload patient where the water getting accumulated in the lungs. Crepitation, if it is present, the characteristics that you all know in a volume overload how it is bibasal infrascapular crepitation if you get, or even in advanced cases, probably over the mid-lung zones also indicates volume overload. Ascites on examination you might get in volume overload patient, jugular venous pressure, JVP, elevated JVP or depleted JVP. You can check the hepatojugular reflex also, and you can see how much JVP is rising on elevating the lower limb. These are all the some methods with which you can assess whether the patient is in volume overload. A elevated JVP indicates volume overload. Capillary refill. You can catch any of the finger, press the fingertip and see how much time it is taking for it to refill. The slower the time, more is the chance patient is depleted. But in a shock patient, this might not work. Each is having an advantage, each is having a disadvantage. What is the disadvantage of this crepitation? Crepitation might be due to because of the patient lung other condition also. For example, pneumonia, which is yes, there are difference in the characteristic. Theoretically, practically, you might have understood how difficult it is to catch the uh, difference based on a particular finding. Yes, it might mimic sensitivity is less. These are in advanced cases. Ascites, is there any disadvantage? Yes, it's a localized collection. The generalizability of this might not be there. JVP might be elevated in cardiac condition, not only in volume overload. These are some of the disadvantages. Capillary refill adds to the clue of dehydration, but might not give much clue in volume overloaded patient. So in the examination, we have seen 8 parameters: BP, pulse, edema, mucous membrane, axillary sweat also you can say. Then crepitation, look for any kind of overload in the form of ascites, anasarca, capillary refill and JVP. If in the context of the history along with the examination finding, if you catch or you have found the patient JVP is elevated, history is also matching, and the patient output is not there, most likely you can very well catch a case of overload or even a depletion using these parameters. History plus examination. Examination, I have told the points. Each is having some kind of suggestion towards the volume status, not clear-cut method. Again, I told each parameter like JVP, capillary refill, Krebs, edema might have its own negative points also. Those we are trying to solve in the subsequent methods. Next is the so in the clinical examination you can see for the orthostatic changes. This might not be in ICU patient. Suppose if the patient is in ward, if the patient is depleted, there will be orthostatic changes in the form of orthostatic hypotension or in the form of orthostatic reflex tachycardia. That too probably might be aware. So next is the imaging. We'll stop the video here. Next, in the next part, I will continue to upload regarding imaging, focus, blood investigation, and the last one is the bioimpedance. We'll see in the next part because Because of some technical issue, I could not upload a video which is more than 20 or 25 minutes. So that is why I'm stopping it here. Another part is getting uploaded soon.